you for tuning in to the Red Clinic podcast. I'm Dr. Schwalen, licensed psychologist and expert in the treatment of eating disorders. Today, I have two very special guests, team members at the Red Clinic, licensed psychologists. I'm going to let them introduce themselves real quick. And then what I want you guys to know is that we're going to talk all about how psychologists analyze our clients. Go ahead, Dr. Cooper.
All right. Hi, everyone. My name is Dr. Erica Cooper. I'm a provisionally licensed psychologist and a psychology postdoctoral fellow here at Next Steps. With the Red Clinic, I function as an attending psychologist, meaning that I conduct assessments on our clients who are coming in, and I provide oversight throughout their time here to their therapists and registered dietitians.
Thank you, Dr. Cooper. What about you, Dr. Woolley?
I'm Dr. Chelsea Woolley. I'm a licensed clinical psychologist. I am also a psychologist here in the recovery clinic. Similar to Dr. Cooper, I'm an attendee psychologist, helping to do the assessments and overseeing treatment.
Thank you for your introductions, guys. One of the things I just said was we're going to tell our audience how psychologists analyze our clients, right? So are you guys analyzing me right now?
That's clearly a joke that we get all the time.
Well, let's talk about it. Do we actually analyze our clients? I mean, what is this all about?
I would say we don't analyze, but our training is definitely where we are trained to talk to people and try to kind of figure out and put pieces together on who they are and what's going on with them. So I wouldn't say analyzing, but collecting data.
Yeah. Fact finding. There's a bunch of ways that we can describe what we do, right? How do you describe it to people?
So I describe it as really getting to know someone and understand the underlying processes that are going on, how past experiences inform what's happening right now, right? So why experiences during their childhood have led to particular interpersonal problems or, messages that they received over the years, how that informs how they think about food or their body. All that kind of fun stuff.
Yeah, and I mean, if it's still hard to understand, psychologists, what we bring to the table, there's all different ways we can describe it, right? Earlier I was saying, like, we're kind of like little detectives. We're trying to really, truly find the pieces that help us explain the big picture. Or we're scientists putting a complex puzzle together, and that complex puzzle is you. And so when you come see one of us, that's really how we consider every single client of ours is we don't know anything about you. You know yourself the best. You're the expert in you, and we're the expert in psychology. And we're going to do everything we can to come together to work as a team to help really understand what are the diagnostic impressions, right? So what is going on with you? And then where do we go from there? So let's talk about assessment, y'all. What do you guys like about assessment? How do you use it? And how can you make our clients really understand what goes on during an assessment?
So personally, I love assessment because I love figuring out puzzles. I love understanding people. I love hearing their experiences, the bad, the good, the in-between. And I like making that connection with others and understanding their story. So assessment functions for me as a way of really understanding where this person is right now and what we can do in treatment to help them. Although I'm not going to be their therapist, I'm going to write a ton of detailed therapy recommendations for their therapist, so that that person understands exactly what's, the course of treatment that needs to be laid out, who that person is before they even walk into their office that first time. That's really what it's about for me.
Okay, thanks for explaining that. What about you, Dr. Woolley?
What I really like about assessment is, like you said, putting those pieces together and kind of seeing the journey and the path that the client has taken that has gotten them here. So we're asking them questions about even when they were first born, all through childhood, through adulthood, because I like to kind of see how their journey started, how they've gotten to this point, and kind of what are the factors that have contributed to what they're currently going through.
Okay, and I love that you said we ask questions, right? Because I think that's one of the biggest things that we kind of forgot to mention. So psychological assessment, psychological evaluation, psychological testing, these are all interchangeable terms, right? Even psychological intake. Sometimes offices will use that phrase. But essentially, it's not like you're getting tested, you're not on display. What is it? What actually happens when a client walks in for an assessment?
So I know how I like to start off my assessment is first by introducing myself and telling them a little bit about what's going to happen that day. So I'm going to ask you a million questions, sometimes to the point where you're going to get a little tired of me, and that's okay. We can take a break if you need. And we may engage in some in-person testing that gives me a good idea of particular abilities. And then when I send you home, I'm also going to send you an email with multiple links, potentially, with measures so that you can provide me even more data about who you are, your personality, and the specific symptoms that you experience.
And so, Dr. Cooper, when you say some in-person testing, are you going to be like drawing blood? Are you going to ask me to do like a agility test or run on a treadmill? I mean, what are you talking about?
No. And actually, I'm kind of surprised that you forgot to mention the ink blot as well.
Well, there you go, the ink blot. So here's a splatter of ink. What do you see? Let me tell you what this means about you, right?
So I'm not going to be doing any of those things. Usually the tests that I administer in person are related to things like executive functioning abilities. So those are some higher order cognitive processes. I'm using a ton of psychological terms right now. Basically, it just means those abilities that are unique to humans and they develop over the course of our lifetime. And, really understanding like judgment, reasoning skills, ability to pause or, like inhibit yourself, things like that. And so really
these
simple.
are like little tests that give you an idea of how a client's brain is operating, essentially.
Exactly.
Okay.
Yeah.
All right. What else do you want to say about testing?
So I can talk a little bit more about the online measures. So, the specific ones that we send to you are really dependent on what's going on, what we think would be helpful to figure out more about. And they're just so useful in just further filling out that clinical picture, that understanding of you, so that we understand you as a whole person.
So those are just like basic questionnaires, right? And so when she's saying measures, we use them as a measure of maybe extensive trauma or a measure of depression symptoms or a measure of anxiety symptoms or even personality, right? And so that's what that is really looking at. If a psychologist meets with you for a couple hours and all you did was talk, and then there's more questionnaires that they're sending you, it's pretty much because we know we need to have the full picture. I want the clients to hear out there and the family members to hear out there that your narrative or your version of what's going on with you is really important to us. And so that's why we spend a couple hours just asking you a bunch of questions and hearing it in your own words, what your background is and what you're struggling with and what you want help with. And then we also know that sometimes you might forget to mention something, or we didn't think to ask, or you just didn't think it was important enough or something one of us would care about, and just because it feels so normal, maybe you've been living with that situation for so long that it's not anything you've ever talked about. So those questionnaires really come in handy because they capture some of those things that maybe we haven't spoken directly about. And then we take all of that and put it together to come up with diagnostic impressions and recommendations. What do you want to say about testing, Dr. Woolley?
Sometimes before you even walk in the door, we have also sent you a couple of questionnaires. And those just kind of help us to know kind of where we're starting from. But the other thing I wanted to say is the questionnaires that we send you are based on what we are seeing in the interview. So if we, feel like we need to get more data on this or that, it's individualized to what we think that we need to just continue to put that puzzle together so we can understand exactly kind of what's going on and where treatment should go next.
And go ahead.
I was just going to say that, one useful piece that we haven't talked about yet with testing is that oftentimes the testing that we use, it has been normed on specific populations or a group of people so that we have an understanding of what like the normative range is for scores on those things, so what most people fall into, and so that we can really understand whatever score you're falling on, where does that show you against a group of other people, and in what population, so that we are not just getting a subjective understanding of the things that you are experiencing, but we also have an objective idea of like data, right? It's data driven.
There's an actual science to being a psychologist, right? All right, so now that we've kind of talked about what really is entailed when we're analyzing our clients, right? How do we use assessment in the Red Clinic, and why do we, per your experiences so far in the Red Clinic, why do we make it such a big deal to get that assessment first?
So I would say that without the assessment, and if you just walk in day one to therapy, it's on the therapist to try to collect some of the data to figure out what's going on. And sometimes that can take multiple sessions for that therapist to really understand what treatment should focus on and what the presenting issue is. And the way that we do it here, having that assessment ahead of time, we've done all that work for that therapist. And we have made that puzzle, and we hand it to the therapist and say, this is the journey the client has taken. This is the data that we have. This is the diagnostic impressions. And these are the areas of a treatment. And it's handing them, like I think we've mentioned, a roadmap and say, this is the issue, this is where we think we should go. These are the techniques we think that would be the most helpful after getting to know the client. And that way, day one in therapy, they already have an idea of where they're going to go, what they need to focus on, and what techniques to use.
I'm so glad you brought that up, because I've heard so many clients say, they've worked with therapists for years. They've had many, many sessions with therapists. And it wasn't until they had a full psychological assessment that certain things were brought to the surface. I've had a client, for example, say, yeah, I've been in therapy for years. They never realized that I really struggle in my daily life with perfectionism. And here we are, we've only spoken for 2 hours, and you've uncovered that about me with this personality assessment that you gave me. And so it's so eye-opening. It can shed so much light on where to go next with someone in therapy.
Yeah, and just to add on to that, a lot of therapists really aren't necessarily trained in assessment, right? So oftentimes master's level clinicians, they're trained in therapy and they're great therapists. They can get in there, they can work with you on the issues, but they need to know where to go. They need to know what to do with you. And so if they're spending the first 6 to 8 sessions still just trying to understand what's going on or who you are or what your background is, man, that's a month and a half to 2 months if you're attending weekly of not making much progress, right? So assessment really allows you to accelerate the progress, or the process, I should say, so that we can start digging deep.
Well, I think it's so perfect that you just said, it can be 6 to 8 sessions, sometimes even more, sometimes 10 to 12 sessions, right? And if you think about what it takes for a psychologist to do a full assessment, it's usually anywhere from 2 to 4 hours, depending on what the referral question is, that the psychologist will spend with the client in person, face-to-face, right? Sometimes it's more, sometimes it's less, but that's about average. And then once the client leaves our office, we're spending another 2, 4, 5 hours on analyzing the data, writing up our findings, having conversations with other providers, other people in the person's life to really get a full picture of what's going on. So total assessment time can be anywhere from like 8 to 12 hours. Again, that's 8 to 12 sessions with a therapist, 2 months, or you let us do it all, right? And directly with you and then indirectly behind the scenes, because essentially we're uncovering something that's been a lifetime in the making, right? It's your life that we're really trying to understand. And it does take that much work to get a full picture of someone's true functioning. And you said, it can take so many sessions for a therapist to really understand even what the presenting issues are when we do it that way without the assessment. And I hear so often from clients that they never even gave their therapist that true chance. After about 3 or 4 sessions, they're like, we're not really making progress. I'm not getting anything out of this. And so they end up leaving prematurely. And so now the opportunity to be really well known and truly known and understood, it's lost, because it does take a long time to be truly understood without the initial assessment. So thanks for saying that, Dr. Cooper. That was an awesome point that you made. Welcome. You want to add anything? Are you good? I just want to make sure I'm like checking in with you guys because I have to look to either side, right? All right. So now that we've really established what assessment's all about, right, and why we believe wholeheartedly in it, let's talk about how we use it in the recovery clinic.
So we often use assessment as intervention. I want to make sure that I point that out. So not only is it going to inform our understanding of what diagnoses are going on or what treatment recommendations we're going to be making, but we also use it as an in-the-person moment to when certain things are brought up that we address those right there and then. Right. So I can give an example.
Sure.
So yesterday I had a client who disclosed that she had a significant history of abuse from a former partner. And she had ended the relationship a long time ago, feels like she's moved on from it. But then she found out that he just passed away a couple of days ago and has been feeling sad. And then she expressed, wow, I feel so guilty about that. He was this person, this awful person in my life. He hurt me. And how can I feel sad about him? And so I used that, right? That moment as, oh, no, hold on. Let's stop right here. It's okay to feel sad, right? You loved this person. You had a relationship with this person. It's normal to feel sad. And so let's not guilt ourselves for that. And so that's just like one unique way of using assessment as intervention to not just like build that rapport with the client and get to understand them better, but also provide them with some feedback in the moment so that they don't just leave that assessment feeling bad about themselves.
Absolutely, right? Like we take great care to take great care of our clients when they're with us. And so even though it's an assessment and we have a lot of questions to ask, we're going to put in the extra few minutes it takes to make sure that client doesn't leave, like you said, feeling bad about themselves or sitting in that judgment or guilt. We want to also make sure that we're taking care of that person. That's awesome. Thank you for reminding us that assessment is intervention. How else do you guys think we use it in the Red Clinic?
Well, I think one of the big pieces that we use assessment in the Red Clinic is, as the attendee psychologist, like Dr. Schwalen said, I have now spent 8 to 12 hours getting to know a client in our recovery clinic. And now I'm their attendee psychologist. And so I get to help oversee the treatment. And so I've got this puzzle. Yes, I've handed it to the therapist, but I'm now getting to see the process play out and getting to check in on the treatment and making sure that, the client is getting the care and that treatment's going in the right direction. And so it is nice to see that play out over time and being able to be involved in their treatment. Because I feel like I know them well and I have, learned about their journey, and then I'm able to help as they continue in their treatment and they start to feel better.
And they make progress and you get to see that progress. Right. It's really amazing. I love that part of it too. Okay, so anything you want to add to that?
Yeah, I mean, yes, that's a wonderful part of the process. Sometimes as psychologists, we're put into positions where we don't always get to know what happens next after we do an assessment. And so at the Red Clinic, I like to always tell people who say, "Oh, wait, but you're not going to be my therapist. Like, I just told you all this stuff about me. How can I feel comfortable with someone else?" And I say, "Well, look, here's the thing. You may not see me. You may not talk to me on a regular basis. I am always involved in your care. I am, behind the scenes, still taking care of you. I'm giving your therapist different ideas and helping them understand what's going on a long-term basis." So that's one of the nice things I think about our setup here is that we do get to do that.
Yep. Now, one thing that we do use assessment for in the Red Clinic, especially with eating disorders, because we know they can be very tricky, is what we like to call, it's a very fancy term, it's called differential diagnosis, right? And all that means is we're doing all this assessment in order to have clarity, because eating disorders can show up in so many different ways. I mean, there's so many diagnoses of eating disorders just in and of itself. But then when we're not actually talking about an eating disorder because maybe a client doesn't think they have one or they've never considered it and they just really don't know that that's what's going on with them, they're going to talk about what's going on with them in all different ways, right? So it can feel like anxiety or stomach aches or I'm just trying to lose weight because I have fertility issues, or, it just shows up in so many different ways. It's easy to explain away some of those really concerning behaviors that are that eating disorders are characterized by. And so we need that clarity. We really need to understand what's truly going on in order to be able to help the client appropriately, right? So let's speak to that a little bit. Like, what have you guys seen uncovered through the assessment process? Can you provide examples or just speak to it?
I will say that, eating disorders is not something that's often talked about outside of the psychology field. And so we will see a client that has been in the care of a doctor, and the doctor has not maybe even considered that this client has an eating disorder. And so when we talk about eating disorders being tricky, it's not just tricky for the client or the client's family, it's tricky for a lot of people, even medical doctors who have all this training, because it sometimes hides in different things, or it presents in different ways, and it's explained in like anxiety or stomach aches or things like that. And so over time, coming to the Red Clinic, we know that is the case. We know it hides and it looks differently with different people. And so we, through that diagnosis, through that assessment, we can kind of, say, okay, well, you do have anxiety and an eating disorder as well. And we have to address both of those for you to progress in treatment. And that's how we kind of move forward.
Right, yeah.
There's also a lot of, just to add into that discussion about how eating disorders are sometimes really hard to parse or even understand if they're going on. A lot of times, mental health professionals are not taught to even go there, right? So when I first started here, to learn that we were asking questions like, what's your relationship like with food? What's your relationship like with your body? How do you feel about it? It blew my mind because I had never been exposed to that. And yet I'm trained as a generalized clinical psychologist. And so that's an area in which I should also be probing. I should be asking you questions about that. And then
especially, right, when food is such a big part of every single person's life.
It is. And it really does inform can cause different levels of functioning within our mental health. If we're not feeding our bodies properly, then we're probably not going to be doing great cognitively, right? It's harder to make decisions. Those executive functioning skills that I talked about earlier, it's a lot harder to maintain those if we're malnourished. But then one other piece that I thought of when Dr. Woolley was talking about eating disorders is that we have so many societal stereotypes related to eating disorders, what people look like when they have an eating disorder, right? So we have a picture in our head of what that prototypical client looks like who may have anorexia, not recognizing that actually someone can have anorexia even within their healthy or above their healthy weight range. That it's more about the behaviors than the underlying thought processes that go into that than it is about your weight.
Right. I'm glad that you said that. I also want to add a little bit to what Dr. Woolley said in terms of, there are doctors out there, just medical, family physicians, pediatricians who sometimes never consider an eating disorder. And there's a lot that goes into that. Medical professionals have a lot of training. They focus on BMI, for instance, as like an indicator. They're trained to really look at growth charts and all about numbers and measurements. And, they don't even want to talk about weight if it's fine on the growth chart, right? But if it's not, then you're going to hear from your physician about it. And so a lot of times I hear all the time, overweight clients will be telling their physician, I don't feel good. I haven't eaten in days. I'm having trouble getting out of bed. I'm really struggling here. And the physician doesn't bat an eye at the fact that they haven't eaten in days because that client, quote unquote, is, overweight or obese or whatever it is on their BMI. And right there could be the beginnings of an eating disorder or a mood disorder, that's missed because a physician is trained to look through a certain lens for the most part. I mean, there are really good ones out there that truly understand eating disorders, and then others don't, and that's okay. That's why we're here. And so I hear all the time that it took many, many, many doctor's visits to even end up here at the Red Clinic because no one ever suspected an eating disorder. So I just wanted to add that, because it's not like they do it on purpose. It's just that it really does take a team of people to treat an eating disorder. How else do we use assessment here in the Red Clinic?
So we've been talking a lot about how after our assessment, you may enter therapy with us, but I don't think we've touched on what might also happen after or towards the end of our assessment. So sometimes at the end of our assessment, we determine that it would actually be better for our client if they engaged in what's called a higher level of care assessment. So a higher level of care just means more intensive services. I often talk about services as on a ladder, in that there are several different rungs on the ladder, and we are that bottom rung. We see you once or twice a week for 45 minutes at a time. And so sometimes clients just need more than that, particularly with eating disorders, because they can be very controlling and really aggressively impair this person's life. And so there are different levels of care above outpatient. It's not just inpatient, which is what I think everyone knows about. There's a couple of other levels as well that just vary in their intensity and how often the person's going. And so sometimes we find that we do need to refer someone for an assessment for that level of care, because we feel like the eating disorder or their other mental health issues are presenting strongly enough and impairing their life in a way that we're worried about their safety. And we want to make sure that they are able to engage in the level of care services that they need at the very beginning, so that they can start knocking this thing out and they can get going on building a lot of good coping skills and, working to reduce their eating disorder symptoms or other mental health symptoms.
And I mean, we firmly believe in setting up our clients for success. And so we're not going to mislead our clients on recommendations. We're going to do whatever the data is suggesting. And we're going to tell you what the data says. And then we're not going to back down either. Right, Dr. Cooper? I mean, Dr. Woolley, you've seen that, right?
Yes.
I mean, a lot of times we'll say, right now is not the time for outpatient. We'll be here when you truly are ready for that. But what we need right now is a higher level of care assessment. And then like Dr. Cooper said, the first thing that a lot of people will jump to is, so are you saying I have to go inpatient? Like, that's not happening. And that's not what we're saying. We're just saying we need an assessment team for to determine which level of care you actually need, because outpatient isn't it. And so those in-between steps are also a possibility. There's intensive outpatient, which instead of just once or twice a week is 3 times a week for several hours. There's partial hospitalization, which can be anywhere from 5 to 7 days a week, 12 hours a day. And then there's inpatient and residential and acute and so on and so on. And so people tend to go straight to, oh my gosh, are you saying I need inpatient? And we're saying, no, we need another assessment to determine actually how much we need to increase the intensity of services. And then a lot of times clients will say, well, I'm not willing to do that, or I'll do that after school's out, or I have this really big project on my team at work and I can't leave my team high and dry right now. And we say, well, that's not what the data is saying is in your best interest. The data says that you need help right now, right? Mm-hmm. So how have you handled conversations like that with clients?
One thing I really try to convey is when I have to have this conversation is it's coming from a place of caring, and this is what I truly feel would be best for them. That we don't want to take on a client that could be better served with more support, and that needs more support, because that's not fair to the client. They're not going to get the most out of treatment. They're not going to see the improvement as much as they would if they were at the right level of care.
Absolutely.
And it could even make their treatment, it could even impair them even more if we don't put them at the right level of care. So it's coming from a caring place. It's coming from a place of, looking at all the data and putting it all together and saying, well, this is what it shows. This is what this assessment has shown me, and this is really what's in your best interest. The other thing is, like you were saying, often they say, well, I'll do it when school lets out, or I just can't do it right now. And I often, challenge that and say, it's never going to be a great time, right? But it's always a good time to take care of yourself. It's always a good time to put your treatment first. And if you put your treatment first, you'll see other things in your life. You'll see benefits to other things in your life too.
No, absolutely. And it's something I tell clients too, that you can even put it behind you once and for all if you do it right the first time. Mm-hmm. How do you have conversations with clients about that?
I would echo a lot of the things that Dr. Woolley said in terms of it coming from a place of me caring about you. I want the best for you, and I want you to be the most successful that you can be. And if we stall that higher level of care, ultimately what we end up seeing with those clients is that their progress is stalled, and they end up needing to go to a higher level of care eventually anyway. And then we just spent how many sessions or how many months
or how much money
not making any progress, and the eating disorder continues, right? It continues to feed, it continues to control. And so ultimately, making that higher level of care assessment is saying, I care about you, I'm worried for your safety, and I want you to make the quickest progress you can. This is how you can go about doing so.
So I love that we're talking about how much we care about our clients. On the count of 3, I just want us to look at our respective lenses and say, here at the Red Clinic, we care about you. Okay? 1, 2, 3. Here at the Red Clinic, we care about you.